Hi, my name's Andy Goldberg, and I'm from London, England, doing a talk on the EFAS virtual conference. I'm going to share my screen and talk to you about weight-bearing CT scanning in ankle trauma. Just like to say I'm hugely honored to speak to you, and thank you to the faculty for inviting me in what is a phenomenal virtual congress and hopefully the beginning of many, many more. So I'm a consultant orthopaedic surgeon in London, also involved heavily in research, both in the standing CT scanner and also have a small stake in a mobile standing CT company. So the first thing to say is standing radiographs are really the standard of care in elective foot and ankle surgery. But in trauma, we still tend to use non-weight bearing imaging for the majority of the time. Now, we know that standing CT is fast becoming the de facto standard for many foot and ankle diagnoses, and we're going to talk about some of them in this talk. And the question really is what's the role of standing CT in the management of trauma? And I wanted to explore three real elements. One of them is process, whether there was an advantage to having a scanner and an ability to assess the images yourself in terms of the process for the patient. Whether the radiation dose is increased, because it's obviously important for us to not expose patients to unnecessary radiation, and really whether or not it was provided a diagnostic advantage over and above the existing modalities which we have. So if any of you have not been down to your radiology department, I strongly suggest that you do so and you watch what happens to patients during that process, because it's enlightening. So often patients, especially in trauma where they have to take their shoes and socks off, they have to get up and mobilize onto different implements, where they're often in a lot of pain and they're asked to do different things by the radiographer who's concentrated just on getting the images for you. So it's worth seeing what they do. And this is a horizontal or supine view for what would happen in trauma of how you'd get a DP of the foot. And there's also patient factors because there's variability in the images you'll see. So for example, in the lateral view, if you've got a very wide forefoot, then your lateral will be a different angle subtended to someone that had a very narrow forefoot. And it's important just to bear that in mind, that you're having lots of rotational differences on the imaging that you have. And especially when there's special views, then there's lots of different views that you may have to do with the standing CT scanner, with the standing traditional view that you won't have to do with the standing CT scanner. This is an example. So this is the traditional Kobe view, or the hindfoot alignment view, or the Saltzman view, where you're seeing the tibia and the hindfoot all in one go. And this on the left here is a booklet that was taken from the Royal National Orthopaedic Hospital in Stanmore in the UK. And they couldn't even agree on the name, let alone whether the patient should have their knees flexed or their knees straight, and whether the angle subtended should be 10 or 20 degrees. And so there's huge inconsistency, and often, especially when you're asking for special views like Brodem views, there's uncertainty and unreliability in the images that you're getting back. Now, that's all changed with standing CT, because in a single pass, which can take 30 seconds, or a dual pass, a bipedal pass, which take about 60 seconds, you can then process the images how you like. This is an example of something called Insta-X, where you can see the X-ray representation from the CT, and you can have the hindfoot view, the Saltzman view, straight away with a foot removed, and you can see it beautifully. You can, for example, see here's a whole DP foot, but without the tibia there, which you'd always see a tibia sitting at the back here in traditional X-rays. And this is a very nice view for you to be able to see and look at assess alignment. And all of this can be done at the push of a button. And we did a review of the process time. If you send someone for the standing CT and then process the images yourself, it's just a few minutes, whereas with traditional X-rays, it was often a lot longer, and you may save about 20 minutes in that process. The ability for you to process the images yourself means you always get the images that you want, and often a lot more than you're expecting. So, this is a fantastic addition to the foot and ankle armamentarium. What about radiation dose? Well, clearly we don't want to expose patients to additional radiation. And so this perhaps summarizes the situation. We're all exposed to radiation all the time. So in the background, we get about 8 microsieverts of radiation a day. If, for example, you had a bowl of Brazil nuts, that gives you about 9 or 10 microsieverts. So it's a greater radiation dose than the background dose of radiation. The standing bipedal PET-CAT scan gives you 6 microsieverts, which is less than a background day of radiation. It's less than an international transatlantic flight. In contrast, when you compare that to traditional CTs, it's an order of magnitude lower. And with traditional X-ray, it's 1 microsievert per view, but you're often doing 4, 5, sometimes 6 special views, especially if you're doing bilateral APs. So your radiation dose is significantly greater. So overall, I think the best way I describe it to the patients is it's roughly the same radiation dose as a series of plain foot and ankle X-rays, and a significantly lower radiation dose than standard CT, and roughly the same as a background day of radiation. What about diagnosis? Does it help us? Well, this is an interesting audits that took place, one by my colleague Matt Solon, which showed that in an emergency room, when they would review the X-rays, there was a missed fracture rate of perhaps up to 2.5%, which is quite a high recall rate if you think about it. And in another study, about 80% of those were missed fractures. So there is an issue there. Now, with a standing CT, you're not going to miss a lot of those fractures. So, for example, an anterior process of the calcaneum, which is a barn door obvious diagnosis, both clinically and in fact radiologically, is often missed on plain radiographs, especially if the junior doctor in the A&E examines it and finds some tenderness laterally and attributes it to an ankle sprain. This is a case study for syndesmotic injury. Okay, so there's a 29-year-old male that went to A&E at the time of an injury and was told that it was an ankle sprain and just to get going, don't worry about it. But he did, and 6 weeks later, it was incredibly swollen, much more swollen than you'd expect, and painful. And you can see on the radiographs here, these are standing radiographs, that it doesn't look right, but it could be just positional in the way the X-ray is taken. So I was suspecting a Taylor OCD, in fact, from the clinical findings. So I arranged for a CT arthrogram, in fact, but using the standing CT scanner. And what we found, to my amazement, was a quite significant syndesmotic injury. And you can see here, you can even measure the distance there. There was significant widening of the syndesmosis with Taylor shift. And we've published quite highly on this. So there are 2 references. One in the Bone and Joint Journal and one in Foot and Ankle Surgery on the role of standing CT compared to conventional imaging. And I think it's changed our practice unquestionably in this. What about Taylor osteochondral injuries? Well, this is a 32-year-old lady that the year after surgery had a medial malleolar osteotomy, and a osteochondral plug was placed inside her ankle, and she remained, however, symptomatic. And the scan at a year showed that, in fact, what was a unilateral, a one-sided Taylor defect is now a bilateral, so both sides of the defect, both sides of the ankle, so the tibia and the talus are now affected. And in fact, when you did the standing CT, what we revealed there was that, in fact, this wasn't a unilateral disease, but bilateral disease. Okay, so this patient had a osteochondral plug put in on the right side, but on the left, they had a significant, if not greater size, similar lesion of osteochondritis dissecans. Now, I've had many discussions with colleagues saying, well, you had to do something because they were symptomatic. But often I find now that my practice, if it's osteochondritis dissecans and bilateral, that you can get them back to being asymptomatic without any progression if you do the minimal thing. And often either a steroid injection, rest, or just going in and debriding any loose fragments that may have been knocked off during trauma often gets them back to being symmetrical with their other side. You don't need to do any more, and you can avoid the scenario that happened here. What about ankle fractures? Well, we're getting smarter and smarter about ankle fractures all the time. The big question, the buzzword is obviously, is an ankle fracture stable or unstable? Well, we're increasingly knowing now that ankle fractures are really broken bones around a soft tissue injury. Okay, and there's been some great work out of groups of colleagues like the group from Liverpool and other groups that have looked at the posterior malleolus now and the role of the soft tissue restraints, and the PITFL and the AITFL are essential in the stability of that joint. It's no longer the concept that it's just a posterior malleolar being the size of the posterior malleolar fragment. The other thing to say is that X-rays alone per se are not reliable. There's very good evidence to show that they're not reliable, especially for sleeve fractures at the back of the ankle. There's also very good evidence now that even small fractures, including sleeve fractures, in many cases should be fixed because it's a soft tissue injury of the PITFL and the ATFL and the syndesmosis hence. And in the old days, we used to get patients on and do these stress views where you'd leave the leg hanging to be able to see that a stable, if not stable, became an unstable injury very clearly under stress views. But it's quite difficult and painful for the patients and a difficult palaver to do. And in fact, our research suggests that patients are much more tolerable to standing on the scanner. Even if they have to put the foot down, they can hold on balance and they can even put some load through it. And that's actually far more tolerable than the traditional method using plain radiographs and stress views. And sometimes it changes your practice to not operate because the ankle appears very stable because the deep deltoid's still intact and the deep deltoid appears that this is a stable fracture. You can treat it much more liberally. Another example of an ankle fracture. This is a 67-year-old patient with what appeared to be a Weber B fracture. It's pretty innocent looking fracture and something that traditionally you would just, if you chose to operate, just the registrar would come down or the SHO and fix that. But the standing CT shows this is not an innocent injury. This is quite a serious injury with a fracture off the AITFL pulled off from the anterior tubercle here. And in fact, there was a posterior fracture as well. So this is a very unstable injury with the AITFL and the PTFL both injured. And that's a very unstable fracture that will do very badly if left alone. So it alters your management plan. Sometimes you find things by scanning that you don't want to find, but it's better to find them out. So for example, this is an image courtesy of my colleague Matt Solon again, which has shown a nicely looking reduced X-ray on plain radiographs, but when you scan it, you realize that the syndesmosis clearly was not reduced in this case, even though it initially appeared to be so. And it's better, it's bad news, it's gutting, but at least it's better to know it and get it right first, if not second time, and get it right and perfect the second time going. So it's definitely helpful in post-reduction imaging. Now, here's an example where it may not add a lot to standing CT because this is a barn door midfoot dislocation. And so clearly it's not going to add a lot there other than perhaps understanding the fracture configuration a little bit obvious. But often they're not that. They're much more subtle and they're injuries which you're not sure about. And the standing CT allows you to be able to ascertain that instability much easier and in 3 dimensions in comparison to plain radiographs. So it's definitely helping in that process. And often it can tell you the reverse when it's entirely normal. So in summary, there's no question that it's much slicker to have a standing CT scanner. Now, obviously, not everyone has a standing CT scanner. And so we've created a mobile scanner that can allow people to have a fractionated service, and you can have the scanner for 1 day or 2 days a week or whatever you need to meet your patient demands. But actually, there's no question having that scanner there does improve the patient process and can turn the whole process of going for X-rays and scans into a much quicker, streamlined process and allows you to analyze them better. It's lower radiation than conventional CT, an order of magnitude lower. That's not in question, and roughly the same radiation dose as plain radiographs. And for me, there's no question that it's the de facto or should become the de facto standard for the analysis of syndesmotic injuries. For me, certainly for bilateral tail OCDs, or at least ruling out bilateral tail OCDs, and for the management of Lisfranc injuries. It's also extremely useful for sesamoid fractures and other forefoot injuries, but that's not necessarily the purpose of this talk, and I'm sure you'll hear a lot more from my colleagues, Matt Welk and Martinez Richter. I'd like to say thank you very much. I'm available for anyone to email me at any point about any questions that you've got. Please follow us on our social handles, and please do stay in touch. Stay safe, and thank you for listening.